Okay.
Yeah, ultimately,
So hi, hello and namaste. Welcome to yet another chapter of Coffee or Critical Cases. And today we have Dr. Devraj with us, and he's going to share the insights of polymyxin B on gram-negative sepsis. So welcome to the forum, sir. And we are sure that by the end of this session, there will be a lot of insightful things that we'll be getting. And over to you. Thank you.
Thank you. Good evening, everyone. So, myself, Dr. Devraj Depurkar. So, I am an intensivist. I work in one of the tertiary care hospital situated in Kolkata in northern part, that is Divine Nursing Home. It's an 135 bedded hospital, 30 beds of ICU. So, I will say this polymyxin B, I have used a lot of polymyxin B in a lot of my patients. So I tell this polymyxin as a life-saving weapon for many of my patients, because many of my seeker and sickest patients being rescued with this weapon. Today I'll share my experiences with this drug, which I am practicing critical care for last 20 years. So I'll start with one of my case, which has been presented in our hospital in last Sunday. It was Sunday evening. The patient is a 65 years old lady. She is in hypertensive. Blood pressure remains not very controlled, keeps on changing her medicines, and she is having rheumatoid arthritis, for which she is on some immunosuppressive agents and frequent hospital visits. On last Sunday evening, I got a call from family members that she is feeling respiratory distress, dyspnea, breathlessness. I told to bring her to the hospital immediately. While presenting to the hospital, she was in arrest. In the ambulance, this was fine. While bringing to the emergency doctor found the pulse was not palpable. There was no celtal pulse. She was having gasping breathing. Immediately resuscitation was done. ROSC was achieved after CPR in 2 minutes. After that, putting her on vent, mechanical ventilation, she has been shifted to my ICU. Once we received her in the ICU, BP was not recordable, so immediately she was started fluid resuscitation from the emergency only. ABG has been sent from the emergency, and that ABG came with severe metabolic acidosis, pH of 6.97 and bicarbonate of 6 minus 22 base deficit. Severe metabolic acidosis. While she's in the ICU, she's on 15 ml of noradrenaline along with fluid resuscitation, and she has been given 2 doses, 1 dose of meropenem 1 gram and teicoplanin 400. Shifted to the ICU, ECG being done, no ischemic changes in the ECG, cardiac things ruled out. Then started the management as per sepsis protocol with given fluids, blood pressure support, and along with that, we started resuscitating her, and we have sent all the cultures. Now, that lady were worried about whether this brain function will be, whether she already had developed hypoxic encephalopathy. So, therapeutic hypothermia protocol being done. After 24 hours, she started opening her eyes. Blood pressure has been stabilized. NORAD support has reduced to half. Urine output was very low. Her reports came, creatinine was 2.21. Her creatinine was normal in her last visit. Creatinine 2.21, urea was 96. Total count was 27,000. Procalcitonin more than 100. CRP 264. Blood cultures, sputum, ET secretion culture, and urine all being sent. So now, my microbiologist called me up and said, doctor, you're this patient, such and such lady, she is growing, see her gram stain in the sputum culture is showing gram-negative coccobacilli. So as you know, gram-negative coccobacilli, so it's Acinetobacter baumannii, most likely. So then immediately, as because she was responding, and then we are waiting for the culture report, and then Snoret getting tapered, AKI is getting better now. As because her procol was high, she's in shock. So I have to choose a drug for this gram-negative coccobacilli. And most of our Acinetobacter baumannii are sensitive to tigecycline polymyxin B combination. So it's usually resistant to carbapenem, it's CRE. So now the challenge for me is that this patient is having creatinine of 2.21, and I have to give a drug, either colistin or polymyxin. So that's where is the thing, which drug should be chosen. Should I give colistin or should I give polymyxin B? For this patient, her X-ray was showing bilateral infiltrates. So it was right lung, there was consolidation, left also. So it was a pneumonia, bilateral pneumonia. Urine report showed urinary was normal. So we are dealing with a pneumonia patient, 65 years lady, bilateral pneumonia, septic shock, and background rheumatoid arthritis on immunosuppressive drugs. So this is my case. So now I start with polymyxin B for this patient. I'll justify myself why polymyxin B, why not colistin for this patient. I did a self-study in my hospital, in my ICU, regarding colistin, and in two arms. One, because most of my patients are either chronic kidney disease patients or acute kidney injury patients. And I have to choose a drug which is nephrotoxic. So now I have to choose a drug which will not further worsen renal function, and I can do justice to my patient by giving proper dose of the drug so that I can kill the bacteria and I can rescue the patient. So that is where I am just I am starting my topic today is polymyxin B. So as we all know, I am not discussing in details of this polymyxin B. We all know polymyxin B. It's a cyclic polypeptide antibiotic, and it's been discovered long back, 1947. This is Pennybacillus polymyxia. And the colistin, there's another drug which is discovered late. This has been discovered late than polymyxin B. So polymyxin B and polymyxin E is the colistin. So I'll go to the next slide, please. So next slide. Yeah, so this is the chemical structure of polymyxin B. So this is a complex structure of polymyxin B. Next slide, please. Number of studies of PKPD being made from polymyxin B from 1960 to May 2015. A lot of studies being done with polymyxins, and that has been depicted here. So I'm not going details. Next slide, please. So now polymyxins are the polycationic and have both hydrophilic and lipophilic moieties. It's a polycationic regimen. And with the bacterial outer membrane, it interacts with the bacterial outer membrane by displacing bacterial counter loss ions in the lipopolysaccharide. Hydrophilic and hydrophobic and hydrophilic regions interact with the cytoplasmic membrane, just like a detergent. So that is how polymyxins actually act with the bacterial cell membrane. Next slide, please. All polymyxins have a similar antibacterial spectrum. As we know, it covers most of the gram-negative bugs except Proteus, Serratia, Morganella morgani. So these 3 gram-negative bugs which are not being covered. And it covers, as I said, Acinetobacter, Pseudomonas, and other Enterobacteriaceae, which is being well covered by the polymyxins. Most of our patients who we get sensitivity pattern, which is mostly highly sensitive, is polymyxin B. Next slide, please. This is susceptibility breakpoints of polymyxins. And if you see the polymyxin and colistin, it is almost same as per the susceptibility pattern and MIC and things are concerned. It's more or less same. Next slide. So I'm not going to say it's a colistin. It says PKBD in the module of the colistin. Today I'll be telling mostly about polymyxin in comparison to colistin. So I'll just not discuss details about this slide. Next slide, please. So colistin and Pseudomonas aeruginosa, this is some slide with log reduction is this, and this is just a brief. It's specifically about Pseudomonas aeruginosa. Pseudomonas is one of the very high virulent gram-negative bugs, and we are very much scared about this Pseudomonas. Though we get a lot of cases Pseudomonas, so we are much more scared as compared to other gram-negative bugs. Next slide. Similarities of polymyxin and colistin, I think it's more or less a spectrum of activity, mechanism of action, everything is similar. Only thing, if we consider a patient of external ventricular drainage is there, and you want to, and that patient has developed meningitis because of some gram-negative bugs. If we compare to the polymyxin and colistin, colistin is probably it crosses barrier, but it's a very poor absorption. So anyway, you have to give intrathecally or in the drainage. But polymyxin B probably will not be a very good option in that case, for a case of where the patient is having gram-negative infection of the intracranial or Next slide. Activity of polymyxin, a novel poly analog is, so this is analog and versus polymyxin. So there it has been mentioned, the MIC of CV1, which is an analog, 2-fold higher than polymyxin B, and cross resistance was observed. So the analog of this polymyxin B has having 2-fold higher activity, and its cross resistance also more. In these drugs, they are actually getting more cross resistance. Next. So comparison of 2 different salts is in colistin, colistin sulfate and colistin sodium. I am not going in details of the colistin. I'll stick to my talk to the polymyxin B in this regard. Next slide. Polymyxin B and colistin disposition of. So this is how, once you give polymyxin B, this slide is very important. So if my patient is having urinary tract infection, polymyxin B is not a very good choice of drug if the patient is having UTI because of resistant gram-negative bugs. Because you see, polymyxin B is having very less renal clearance. So that is why the drugs will not get considered in the renal system. So it won't work in UTI, MDR UTI. There, in that case, if you see the colistin, it is other more on the renal excreted side. That's why its action will be better for an UTI with MDR. Now that is the reason, probably the last study which has come regarding the nephrotoxicity, these 2 drugs, colistin and polymyxin, both are having neurotoxicity and nephrotoxicity. We all know. Now the last study which has come, that has told us that nephrotoxicity is comparatively lesser in case of polymyxin B than colistin. Probably that is the reason, because this drug's concentration in the renal system is less as compared to colistin. Next slide. Polymyxin B, we all know the doses. We all know for the adults. I'm talking about the adults. For adults, now the dose is 15 lux IV bolus. That's a loading dose, followed by after 12 hours, 7.5 lux twice daily. That's for a standard body weight patient. That's a standard dose of polymyxin B, and that has to be considered. I would like to add on. So this is the point where I would like to add on. If my patient, I would have been giving colistin, probably after 48 hours or so, I have to reduce the dose of colistin. Now I'll come to in one of my slide where I am still continuing that study. In the study, I have found the patient where I am giving the full dose polymyxin B, and the other arm I'm giving compromised dose of colistin. I have seen my patient's mortality benefit and responses are better with the polymyxin B arms as compared to colistin. Next slide, please. So this is just colistin with sodium and colistin with sulfate. Next slide. Next slide. The same thing. Next slide. Next slide. Colistin with the sodium. I have discussed about this. Next. Polymyxin B and colistin PK parameters. It's more or less, compared to PK, but it's almost same. I would not say there is any much difference, but it will be same. Next. Next slide. Difference of polymyxin B. Next slide. This is colistin. Polymyxin B and colistin. This is, I have only one difference to say, as I said, and probably I'm still continuing with that, my in-hospital study, and probably I need large number of patients to probably, get a solid stump on that my in-house study. So I would say one difference from polymyxin B, I am giving full dose for my renally compromised patients. For colistin, I had to reduce my dose for those patients. And I am seeing till now, my patients, those who have received full dose polymyxin B, their outcome was definitely better. Next slide, please. Next slide. Next. 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 Next slide. Next slide. Next. I'll skip this colistin part. Next. So now this is hydrophilic. So hydrophilic, So a little bit we need to hydrophilic and lipophilic antibiotic. I think you all know hydrophilic, and there are two types of hydrophilic and lipophilic. So these are some of the things which are the lipophilic antibiotics like tiacycline, fluoroquinolone, macrolide. These are all lipophilic. And in the hydrophilic group, you have this colistin, polymyxin, vancomycin, all this. So this is a hydrophilic, and also it has some lipophilic effect also. Next. Next slide, please. Next slide. Inhaled. So again, one difference I'll tell. For colistin, we can have this ability to use the inhaled. Inhaled colistin we can use without any dose reduction. Polymyxin, again, you don't need any inhalation dose. There is no inhalation dose for polymyxin B. So there is one more difference. For colistin, we can have some inhalational dose for colistin. But for polymyxin, it's only systemic dose. Next slide, please. Next. I already said intrathecal, intraventricular colistin has a role. Here again, for those patients where you need to cover the intracranial infection with some gram-negative bugs, which is MDR or CRE, there again, we have to depend on colistin. And that needs to be given to achieve the more drug concentration, probably intrathecally or intraventricular, we have to give. Next slide. Next slide. Next slide. Next. So now, see, regarding this, see, in my hospital, I have till now, I have 20 number of patients. Somehow this slide is missing here. 20 patients in my ICU. I have done a study where 12 patients were patients of 12 patients received polymyxin B and 8 patients received colistin. Those patients all are having pneumonia. Pathogenic agents were Klebsiella and Acinetobacter in my ICU. Now, out of these 12 patients who received polymyxin B, 8 patients were AKI due to severe sepsis, septic shock. 4 patients were chronic kidney disease who were on dialysis, came with pneumonia, and developed AKI on CKD. And out of these 8 patients of colistin arms, 4 patients were CKD and 4 were AKI. Till now, which in these 12 patients, I have used full dose polymyxin B. And in those 8 patients, we have reduced the dose of colistin. For those CKD patients who are on dialysis, very minimum dose they receive. And for those AKI patients, little higher dose they receive as per the creatinine clearance. Out of this 8 patients in the colistin arm, 12 patients in the polymyxin arm. Out of these 12 patients, 10 patients survived, 2 patients died in that polymyxin B arms till now. And in this colistin arms, out of these 8 patients, we could not rescue a single patient. So now, out of this is a very, I need to have a more data on this. This is a very small data which I have collected. Out of this polymyxin B group, I have rescued almost 10 patients, 2 patients died. And here, they in this colistin group, they needed dialysis, a lot of things, and then of these 8 patients, they died. Now, I will not say this all colistin receiver patients are dying. There are patients who are surviving also. But then I have seen the patients who are having renally compromised, who are not getting full dose of these drugs, probably the mortality benefit is having some problem as compared to the full dose and nephrotoxicity. So that is why today my take-home message for this CMU will be the judicious use. It's very important regarding this gram-negatives, because this is a life-threatening disease. Gram-negative, MDR, gram-negative, will lose a lot of our patients. So I have seen many of my patients, they are responding well. If I am giving, number one, if I'm giving full dose of that drug, my number one point. And number two, as compared to the 2 drugs, nephrotoxicity is lesser in polymyxin B group as compared to colistin. So that is why my take-home message for gram-negative sepsis having pneumonia and probably some blood-stimulated infection, if we use polymyxin B, probably the mortality benefit is better as compared to colistin. So I would conclude here today, but I need to have much more inputs on this study so that we can actually look forward. But then again, if it's an urinary tract infection, then in that case, we have no other option. We have to use colistin because that is the only drug which gets accumulated there. And in my this 20 patients, all those were pneumonia patients. So as because I am doing study with pneumonia patients only having MDR, CRE, gram-negative bugs. So probably it will take some more time to get large number of patients so that we can come forward and we need two groups, two arms, again, colistin and polymyxin B. Thank you.
Indeed, sir, it was a wonderful session. And now I request the participant, the forum is open for question and answer. You can unmute and ask your concerns or share your concerns with the sir.
Hello. Sir, I have a question, sir.
Yeah, please.
Sir, my question as we are saying that for the renal compromised patient, as you are described very well the scenario of a 20 patient, you are applying 12 for polymyxins and 8 for the cholestyramine. So, sir, my question is that what is the opportunity to promote polymyxin to the nephrology? Is there any, vast? So actually, I want to know what is the particular indication to promote this polymyxin B into the nephrology.
Right. For nephrology patients, most of the time you find the cases, most of nephrology patients, they carry a dialysis catheter. Either it's a femoral or it's a jugular line. And in our country, this line sepsis is very common. But unfortunately, in our country, this CLEP-C or line sepsis is mostly with the gram-negative bugs. As compared to the others, mostly it is a gram-positive. But here, we get a gram-negative sepsis common, CLEP-C. So either it's a Klebsiella or sometimes you might get Pseudomonas. So probably those patients who are on dialysis or the patients who are having, slightly higher diabetic kidney disease, not a CKD, diabetic kidney disease, the patients having creatinine of 2 or 3, probably in that case, if the patients having CKD patient having line getting infection, or that patient, diabetic kidney disease, had gone to the hospital for something and then had a central line infection. In that case, probably if it is a MDR gram-negative bugs, then probably I would prefer this polymyxin B because here, again, colistin, if you give, then you have to reduce the dose. And you have to monitor the renal function. And again, here in polymyxin B arms, I think the dose reduction is not required. And nephrotoxicity is the last study, as nephrotoxicity is less as compared to the colistin. So probably in those cases of your line sepsis and pneumonia patients who are having renally compromised, probably CKD or diabetic kidney disease having pneumonia with MDR bugs, probably this polymyxin would be a better option if that is an CRE, if it is resistant to carbapenem and sensitive to polymyxin colistin. There we can probably use this drug. Again, if it is an UTI, urinary infection, then polymyxin B will not work because it's not getting excreted in the renal system. So there we have to use colistin and we have to reduce the dose as per the creatinine clearance.
Okay, sir. Thank you so much. So, sir, can we promote like these doses of polymyxin?
Yes, for even for the renal
The success rate of polymyxin as well as economical to the patient also.
Yes, and we are not reducing the dose. We are not reducing the dose of polymyxin B. If the body weight is more than 60, standard dose. If it is less than 60, underweight, then we have to reduce.
Okay,
the
sir.
dose.
All right, so we can take one last question and then we can conclude. If anyone wishes to ask or raise the question, can unmute and ask the questions. All right. So, sir, I guess it was an indeed insightful session, and the time was the session went so fluid that I personally was not able to look at the watch and see the time. It was so fluid. So, thanks for
you.
your insightful words and talk. I'm sure that the insights that you shared are going to certainly help the healthcare professional out there who have been participated for this session to treat the patients. So once again, thanks from entire Poland team, and also thanks to entire East Zone who helped us to arrange this wonderful session. And from entire Poland team, until next time, signing off.
Thank you. Thank you. Thank you.
Thank you so much.